Welcome to Gutsy Talks. I'm Rachel Larson, your host, naturopath and nutritionist, and I'm here to have real, honest conversations that can help you heal your gut, calm your mind, and fall back in love with food. Together with leading health experts, we'll dive into all things gut health and explore the deep connections between your gut and overall well-being, so you can feel empowered to take control of your health and live your best life. If you love all things gut health, follow me for more on Instagram at rachel.larson or head to rachellarson.com.au. Now, let's get into today's episode. Today on the show, we're joined by Steph Lowe, the Natural Nutritionist. Steph is a qualified nutritionist who's been transforming lives around the globe since 2011. Her mission? Helping ambitious women reclaim their energy, master their hormones, and finally feel like themselves again. And she's the perfect person to tackle today's topic, iron and B12. Together, we're unpacking how to actually spot the signs of deficiency before it derails your health, why so many women struggle with iron and B12 despite having normal blood tests, the right way to test, supplement, and eat for optimal levels, myths, pitfalls, and practical takeaways you can use today. If you've ever wondered why you're exhausted, foggy, or still low in iron despite trying everything, this episode you just don't want to miss. Welcome, Steph, to the podcast. I'm so excited to have you here.
Me too. Looking forward to this chat.
Yeah, it's nice. What we were saying before I press record is that I've been on your podcast and it's nice to return the favor because you're such a wealth of knowledge. And while you're extremely versed at being the interviewer, it's now nice to be the interviewee and have your moment in the spotlight to really share, your years and years and years of clinical and practical and just like personal wisdom on such an important topic, which is iron and B12, right?
Yeah, I'm looking forward to it. Like we were talking off air. I had a podcast back when podcasts weren't even a thing, right? So we have nearly 600 episodes that I'm really proud of. We've had a little hiatus this year. We may come back, but yes, I'm on the other side of the mic for now. So that's fun too.
And that's good for anyone listening to this. There is like 600 episodes of information from Steph. If you love what she has to say today, I know you will. So, if you love her vibe and want to go more into different topics, like her podcast, Health, Happiness and Humankind, is on all the streaming platforms as well. So a great resource for anyone as well as Gutsy Talks. So let's get into iron and B12. And I guess it's always good to start with the basics because it just lays the foundation for some of the nitty gritty stuff we might get into later. But for anyone who is thinking or knows that they're maybe suffering from a deficiency in either of these, what are the key signs and symptoms that iron and B12 are maybe in fact deficient?
Sure. So that's a great question. Good to start with. What I want to say though, as a little bit of a caveat, I think which you'll hear when we start talking about the symptoms is one, there are common symptoms between both an iron deficiency and a B12 deficiency. Two, there are some differences, which would a clinical picture would lean towards one more than the other. But three, some of the symptoms could be caused by something completely different, right?
Yes.
So if we start with fatigue, right? So probably the most common symptom of both iron and B12 deficiency is fatigue, but I'm sure you could agree that could be caused by a dozen different things, right? So before I just go on to the other part of the question, I think we really have to be mindful of this because what I see is people are tired, they might find low ferritin on their blood test review, and we'll sort of dive deep in this today, but they kind of just connect the dots and go, okay, I'm finished.
Yes.
But we know that correlation doesn't equal causation. So we always have to make sure we zoom out when we look at symptoms and what they might be caused by.
Great caveat to start with, for sure, especially the symptom of fatigue. Like, goodness me, we have endless lists of things where fatigue is a top symptom. So again, we're just not saying just think about iron and B12, but, again, correlation, causation, what you mentioned.
Absolutely.
So I guess with that being said, what are some of those signs and symptoms?
Yes. So the next sort of ones that I think are very common, especially when it relates to iron, is that shortness of breath. There's definitely the dizziness and the brain fog. If then the iron deficiency is progressing, that's where we can start to see, restless legs and brittle nails and hair loss and even pale skin with the real sort of dark heaviness under the eyes.
Yep.
Quite a different, the sort of broad collection of symptoms. B12 can then also look like the tingling or the numbness in the peripheries. You see definitely mood changes. It can really look like depression in a clinical picture. There's memory problems. B12 deficiency can also cause or be one of the drivers of iron deficiency anemia or IDA. So then it can have all those other symptoms that we mentioned in relation to iron.
Yep.
They're pretty broad, but they're also obviously an awful collection of symptoms, and very common, very, very common, aren't they?
Definitely. And I think that's kind of why, we really need to talk about this in more detail, because so many people are going to be like raising their hand saying, oh, well, I can relate to that. I can relate to that. And so we, giving people a bit more information as opposed to saying this is the only cause, or, what else can be involved, the fact that they can work together. Again, it's just really about making sure people don't pigeonhole that is their only issue, and just kind of keeping a few other things on board as well. And I mean, gosh, I'm jumping ahead, but even when it comes to the testing aspect, like there's a lot to say about that, which I can't wait for you to answer.
Yeah. We need to unpack that.
Yeah, definitely. So I guess before we talk about maybe what causes some of these iron and B12 deficiencies, and again, just recognize that they are two separate nutrients that we're talking about, even though I'm saying like iron and B12. Can we please just talk about how iron is absorbed in the body and B12?
Yeah. So separately, they do have different mechanisms. So iron is obviously something that we ingest in certain foods. It's mainly absorbed in the small intestine. We know that heme iron, which comes from animal foods, is more efficiently absorbed. Non-heme, so plant-based sources, you have a lot of inhibitors like our calciums and our phytates in things like vegetables. It's influenced significantly by enhancers like vitamin C. So they're different in terms of the source of the iron.
Yep.
Yeah, but mainly in the small intestine, whereas with B12, it's a lot more to do with the stomach, right? We require a lot of stomach acid, and that's a key piece of the picture if we're looking at true vitamin B12 deficiency.
Yep.
Because low stomach acid can be a driver, and we'll get to that with our root causes. But yeah, B12 is really dependent on a healthy stomach and also entire gut function, of course.
So this is also why I got you here, is because, there's a lot of gut that we're talking about in this, which is, my clinic, which is predominantly gut related stuff. Like and you see it in your clinic as well. You obviously touch on gut, but like there's just so many things that are happening in the gut which could be contributing to an absorption issue and a deficiency kind of in as an end result. So let's talk about, I guess, some of the really common causes of iron and B12, because these aren't just gut related. So let's kind of talk about these.
Yeah, so I think you raise a good point, at least in my echo chamber. I feel like people are becoming far more aware of obviously gut and the microbiome. And it's quite common for me to be sort of told by someone that they think they've got low iron or low B12 because of an absorption issue, right? So that root cause, I think, is at least somewhat understood and starting to become a lot more understood.
Yeah.
But what I always say to people is, like, if you have an absorption issue, you're not just going to have low iron or low B12. There's going to be a much more obvious clinical picture with like unexplained nutrient deficiencies based on like a dietary intake, right? So yes, I think the gut and absorption and the ecosystem are all really important. But I think that's more of an obvious one because one, it's more accepted, and two, you can see it when someone's got that broader absorption issue. Does that make sense?
Definitely. Yeah. Hopefully people at home are nodding saying, yep, that makes sense.
Now, I understand that you would see a lot of this because of your clinic. I don't. I do not see many low iron or low B12 issues that are related to the gut. I'm not saying they're not common. I'm sure they are common, and you can speak to that. But naturally, when you work in hormone, they're more of the root causes that you'd see, right? So absolutely, 100%, the most significant root cause of low iron that I see is heavy menstrual bleeding. And for us, that's obvious, but I can't tell you how many times I've had people have all the light bulbs in the world go off because they've finally realized that, one, their menstrual blood loss is not normal, that it's
Yep.
actually clinically defined as menorrhagia, so
Yep.
heavy menstrual bleeding, and that is where all their iron is being lost. And they're like, oh, so I actually don't have a true iron issue. That's the secondary issue
Yep.
to the heavy menstrual bleeding. And then we have to find the root cause of that, which is my job, right? Because there can be one or there can be many.
Yep.
So it's the iron losses. This obviously is targeted towards a menstruating female or AFAB. So we do have to obviously look broader depending on who the client is, but I'm naturally seeing mostly menstruating women. So heavy menstrual bleeding is the biggest root cause.
That needs to be solved. Like, because again, like it's like you said so well, is that the absorption issue is so well kind of recognized now that it's like, oh, that must be it. And you're like, wait a second, like talk to me about how many times you're changing a tampon or a pad, like, or how are you having really frequent periods? Like, is actually the loss, which again has then got all of its other driving and causative factors that you need to explore. So I think that was like, again, people listening to this, I hope they're like, oh, I'd never even thought about blood loss. For people who, I guess, aren't really aware of what is considered menorrhagia, what are we talking about? So people
Yeah.
can start to be like, oh God, I use that many tampons, or I use that many
Totally,
pads.
totally.
Yeah.
And a couple of things first. So
Yeah.
like I'm born in the 80s. A lot of my clients are like not necessarily maybe as old as me, but they're at least in their 30s. So there
Yeah.
might be a 90s bub. Most of us largely grew up in a generation where menstruation was taboo. Now, this is not everybody, but like I learned what I knew at the time from Girlfriend and Dolly magazine.
Yeah,
And then
Dio.
magically appeared a packet of pads on my bed when I got my period. There was literally no discussion. Bless my mum. It was just what was done at the time, right?
Yeah. Yeah.
So what I find really interesting is now we're having this conversation with 20, 30, 40-year-olds, and literally for the first time, they're learning that their period is not normal. And that to me is wild, right? And so I think we've confused common with normal because you might be talking to your girlfriends and it sounds relatively similar. And so you literally do not look any further. You think it's normal to be bleeding through, to be having clots, to have this significant impact on your quality of life every single month. Until you have a conversation like this, where you learn that between 40 and 80 mils of blood loss per month is normal. So that's 4 to 8 super tampons, full stop.
Yep.
Including like obviously what you can't measure because it will be like in the bowl or what you have leaked through. And obviously it is grey at best. So the only way to truly measure what you're losing is if you are someone who can use menstrual cups because they're pretty clear.
Yep.
Depending on how much is lost in the bowl.
Yep.
What I say to all my clients is just create a rough log, right? Whether it's tampons or pads or cups or undies, just create a rough log of what you're using. And then we can roughly work out, okay, a full regular pad is 5 mils, a full super pad is 15 mils, a full super tampon is 10 mils, and we can do the math.
Yeah.
And it's pretty easy as soon as someone starts talking to you to be like, all right, well, you're already over 80 mils and you're only at day 2. So
yes, we don't need to go further. We know that there's excess. Yeah.
We do go further because I really like to quantify because some people it's like 120.
Yeah.
I've worked with women who are like 300 mils per month. Yes, wild, right? And so it's really rewarding to each month or each, whenever you're getting your improvements to see the improvement.
Yeah.
Because 300 mils is not going to get to 80 mils in 1 month or maybe not even in 3 months, depending on what we're dealing with. So to be able to see those improvements are a big part of the motivation as well, right? With things that are harder to fix in some women.
And that makes sense. Like actually, even though I said you don't need to go further, as you said, like there's, why you do that is, the same as kind of tracking people's symptoms because there's no overnight fixes, but we can track improvement. And if it's kind of going in the right direction, then, you're on a winner in terms of your clinical protocol and, understanding those drivers and things like that. So that's really good to know. So again, absorption and loss, it's both can be true. We just need to be kind of looking at the picture holistically and not kind of pigeonholing ourselves in terms of, oh, it has to be my gut. Again, other factors that we need to be aware of. I love that. So can we please talk about the difference between an iron deficiency and iron deficiency anemia? I feel like sometimes these terms around iron are used really interchangeably. And like, I just want to get really clear in terms of the actual pathology and what constitutes as an anemia or just iron
Yeah.
deficiency.
Yeah, I'll start with top level,
Yes.
because when you've got an iron deficiency, it's like you've got low iron stores. So not a lot of what we'd call surplus, not a lot of leftover iron.
Yeah.
Whereas when you move into deficiency, like an IDA, so
Yeah.
iron deficiency anemia, that's when you also see your hemoglobin significantly drop. So hemoglobin is a really important marker. Unfortunately, it sits apart from the iron studies when you do your test with your GP. So they're not often looked at collectively, which is disappointing. But hemoglobin is actually where most of your iron is stored in your red blood cells. And so you can have low ferritin, but you can have adequate hemoglobin and not necessarily have severe symptoms. It depends on the individual. But IDA is quite serious, right? When your hemoglobin drops below range, that's when you're really starting to get into a clinical picture that is definitely very serious. Arguably, you shouldn't have got there in the first place, because if you were working with someone who knows how to treat you and to monitor you, you would have hopefully picked it up earlier. And that's the point of like proactive healthcare. But yeah, iron deficiency and anemia is quite a severe condition, and like is obviously a bit of a bigger journey backwards. And there's different treatments that we would lean towards for that.
Yeah, and that's really great to know just in even terms. And again, we're not talking about testing just yet because I want people to still get that, that real ground knowledge there. But even just talking about when people are looking at results that, on that iron panel, potentially the hemoglobin, well, it won't be there. So it's about, I guess, just making sure that like you're asking the right questions, that you've got all your results if you're working with someone to send through not just your iron. There's different hints and other markers that can be used to understand the picture better. So I love that you mentioned that. What about low B12 and pernicious B12?
Yeah, well, low B12 is usually diet or lifestyle or gut, like stomach, like we said, low stomach acid. Whereas when you look at pernicious anemia, that is considered to be more autoimmune in nature, although not really kind of acknowledged broadly as an autoimmune disease at all. But there's definitely something blocking the absorption, and sometimes that can be regardless of your intake. So it's not necessarily like maybe vegans who aren't quite eating appropriately from a B12 standpoint. That doesn't apply to every vegan, I get it. But just to say that, like, obviously the diet is our primary source of B12, but there are other reasons why we might have low B12, as we've discussed.
Yeah, so again, we're looking at the different root causes and pathologies are slightly different. And that will then obviously take effect in terms of how it's managed as well when you understand what's causing it. So okay, let us get into the testing. So the best way, I know, because I'm like, no, we're not going there yet. And everyone's like, just tell me about the testing.
There's so much to discuss here. Yeah.
I will let you run with it because I know that you've got so much to say. So iron, B12, how do we best test them?
Well, so I think the first thing to understand are our testing conditions, right? Because notoriously, this is not what's discussed in the more Western model. And then you and I are receiving results that basically need to go in the bin because the results are what we call confounded. They're incorrect by certain variables, right? So there's not many blood tests that can be done in the fed state. Yes, if you're doing like thyroid antibodies or something like that, you can. But truly, the vast majority, like almost every single blood test you can think about, should be done in the fasted states. That means no food or beverages that contain calories. But equally, we don't want to have an extended fast, right? So we sort of talk between 5 and 12 hours roughly as a fast. Iron is significantly impacted by anything that's considered inflammatory. So that's alcohol, that's high intensity exercise, that's you being unwell. So we have to really try and control the variables in the 48 hours, even longer for some people. I can give you some examples in a moment, but 48 hours prior, we have to follow all the rules. If we happen to get sick on the day of testing, we should just delay that test. So that can be a little bit of a logistic thing sometimes with like practitioner appointments and things like that, but you still are best following those conditions as much as possible. And specifically when it comes to iron, we always have to think about what cycle week our menstruating female is in, because your iron levels are going to look very different if you've just finished bleeding versus to you being in week 3 or 4 of your cycle, right?
Yeah.
So I tend to do everything in week 3. It is always, well, almost always a time that we're testing hormones and other variables that we're looking into. So I give that, unique recommendation to my client. But as you can see, there's already a lot that we have to think about prior to even getting to the pathology lab.
Yep. Which is important because, again, like if you're going to go to the effort of getting a blood test, you want to know that what you're actually testing is the true state of your iron. It might sound like we're trying to line up planets and lunar cycles and things to get the right tone. But, like it's not because we like being annoying. It's because we're wanting data that we can truly work with and say, this is the truest state of what we're picking up. Because, like it might be annoying to reschedule an appointment, but, wouldn't we rather be working with what's actually happening?
Oh, and you can spot an iron studies in the fed state a mile away. They look bizarre. Like they don't even make sense. You'll have like, we'll talk about the different ions and transferins and things like that, but they're so obviously incorrect because of the mechanisms of iron utilization and movement into the circulation once you've eaten, right? So they're weird. They don't make sense. So let's not waste our time and also like Medicare resources, right? Because that's one of the problems that we always face when we're looking at proactive care.
Yeah.
Our challenge in Australia is we have an incredible system for sickness and reactive care, but not proactive care. So we want to make sure we're doing it right? Not to waste resources and have to go and repeat a test.
Yeah, and that's an excellent point. Excellent point. And so aside from obviously all the moons, stars, planetary issues that we need to line up to have these blood tests, and I say that in a joking way, but absolutely what you're saying makes total sense. So when we're getting our tests, like what are we testing for? What do we want to be tested for?
Yes. So we always have to ask for the full blood evaluation, FBE, or it's sometimes referred to as a complete blood count or CBC. That's where you find your hemoglobin plus all your other red and white blood cells. So we absolutely have to make sure we can interpret that with our iron studies. Now, we need full iron studies. So that's iron, transferrin saturation, and ferritin. So please, not just ferritin, because you cannot interpret iron studies from ferritin alone. Yeah. I always ask for C-reactive protein as well, because inflammation is a confounder. We have to rule out inflammation. Obviously, it's pretty crude. It's not the only marker of inflammation, but if it's high, so if CRP is above 5, I mean, obviously optimal is about 1, but if it's above 5, you'll be red in a Western pathology reference range. Yeah. And you can usually see that the iron studies don't make sense as well. So that's where it's like a confounded test result. But you need to know that right before you start interpreting results that actually aren't true.
Yeah. You need to know all the, again, different pieces to know exactly what you said. Yep. And I guess like in terms of anything else that you'd be wanting to know for iron, and I should actually say, what do people do if all their GP, and again, we know that GPs answer to Medicare, so it's more just a fact of maybe they can't refer for certain tests, but like, is there a way, if they're only getting referred to ferritin, for you as a practitioner who's trying to see that whole picture, to get the iron, the transferrin saturation? Like, do you ask that they test in a private sense, like out of their pocket, or like, how do you navigate that?
Well, if you're only getting ferritin, doctors miss the mark. So far, we're not mentioning anything that's a fringe test. Yeah. They are all Medicare approved. For sure, the client can pay, but that's not where I'd be spending my testing budget, because I'm wanting to do hormones and all the things that definitely are not Medicare approved. So I'm trying to allocate my budget there. So it would be either developing language to communicate with your GP as to why you want more than just ferritin, and like your practitioner, we can help you with that. Yep. Or it would be another GP who comes on the health journey with you, because I know this is going to sound a little bit crude, but we hire our GP and so we can fire them. Yeah. We can find someone else.
It's all about having the team that is most supportive to you.
Definitely.
If I guess, yeah, you think of it in other ways, like it's a team that is, yeah, it's your team. So if you're someone that's like, man, they're not playing ball, is there a better person out there? And,
Definitely.
there are other GPs. There are also other naturopaths and nutritionists that you can go to. Again, if your practitioner in that sense doesn't feel like they're part of the team or isn't quite the right team member, again, it's about having a team that supports you. So they're really good points, especially about the education about language and, I guess conveying, the need and the want to have these tests just to see if that GP can hopefully come to the party if they're currently only wanting to test ferritin.
I think health advocacy is such an important skill for us all to have.
Totally.
It is a relationship. So we're not going in there like demanding things and
Never.
carrying on like a pork chop. It's about a, reciprocal relationship, but having the language, like I don't expect you to have that straight away, but being able to advocate for yourself and say, like, I'd like to truly understand my iron studies. I understand that ferritin alone is not enough. Could we please order full iron studies and a CBC? They're not going to say no if you're polite and you explain it from a point of understanding and your health journey rather than it being like a conflict. Like too often I hear about conflict between people who are proactive coming into a reactive system. It's not always easy, and I definitely appreciate that. It's for me, I'm a good health advocate. I've been doing this for 15 years and I've been in the health industry for 25, right? So it's like I understand that for someone that might not have our language, it can be confronting, but I think learning the skill is so important.
I think that's well said, and that respect, is really important, to everyone's position in the team that you're working with. What about B12? Is B12?
Yes.
Yeah. What do we want to know when we're testing for B12 accurately?
Yeah. So serum B12, our typical B12 that you'll probably see on many general Medicare or GP bloods can be quite misleading. So we like to try and do what's called active B12. Sometimes it's written on the report as holo TC. I won't try and pronounce that word. For some reason, I cannot say.
That's enough. Holo TC is great.
Active B12. And look, there are other tests that we can do that sit definitely outside Medicare, whether we're looking at like more methylation markers and things like that. But on every GP referral that I write for my client, I'll write serum B12 and total B12. And it's becoming a lot more common that we will get a total B12 back. We're looking for greater than 100, and that tells you much more about essentially the bioavailable B12. So it's a more sensitive marker and more an accurate representation of true sufficiency or deficiency.
Yeah. Great to know. Again, am I being tested for that? And again, are you potentially having a practitioner that can help with that process if you're only actually getting a serum at the moment? But I also have seen in my clinic I think a few more actives come through, even like without my request, just they would be getting their bloods and, they would be bringing them to me and seeing that. So that's good to see as well. So let's talk about, now that we know, I guess, the types of tests that we're wanting to see, I think it's now the fun conversation of the difference between optimal and reference ranges. They're different. So can we please talk about those reference ranges that are given on a test and those optimal ranges that maybe we'd be wanting to see for our patients?
Yes. And I think this is probably the most important takeaway. I mean, your audience might already be familiar with it to a sense, but the reference ranges that we see on the report are basically as wide as a house. And that's based on the population as well as in-lab data. But they are to exclude like severe diseases. They are not talking about optimal health.
Yep.
They are not sex specific. They're not even specific for like menstruating versus non-menstruating women. They're certainly not pregnancy specific either.
Yep.
So if we use ferritin as a primary example, that lab reference range is going to be for you, for me, for someone who's pregnant, for a 100 kilo male, for a 50 kilogram 70-year-old, for a 30-year-old with heavy menstrual bleeding. And you can already see how that's just crazy, right?
Yeah.
So a lot of people are being misinformed about their levels based on that reference range.
Yeah.
And so we have to keep that in mind. I mean, it applies to almost every test, but I think ferritin is the one that is probably the most misleading that I can think of.
Yep. Yep.
Yeah. The other thing that we look at with women specifically, so we use a reference range of 30 to 100, right? And if you look at, like, say, Australian data, the median, which is like the average of a menstruating female, sits around the low 40s, like 42 or 43 or 44 or to 45. But most women are being told that they've got an issue unless they're 100. And I have a problem with that for a few reasons. One, it's not evidence-based.
Yeah.
Two, it depends on her size.
Yeah.
Because, you know, you might weigh 45 kilos or you might weigh 95 kilos and you're going to have a different storage capacity. The other consideration is, unfortunately, the women who have a ferritin of 100 usually have another issue. They're either not menstruating, like they've got hypothalamic amenorrhea, and that's a huge problem, or it's actually, ironically, an inflammatory picture. We have to remember that iron's a heavy metal.
Yep.
It's, from a nutrient point of view, it's Goldilocks. We definitely don't want too little, but we definitely don't want too much.
Yep.
So we shouldn't be striving for these higher end values, which would ironically be inflammation and a huge red flag for something else that's going on in the body, or an absence of a menstrual cycle, which is a massive red flag as well, right?
Exactly.
Yeah. So most of my women I want them above 30, but I'm not just looking at their iron studies through ferritin alone, mind you. So we'll get to the others. But I don't actually see optimal as being much above 50 for a menstruating woman. It will climb post-menstruation, of course, like when we're going through and we're post-menopause. But I think for our audience, somewhere between 30 and 50 is adequate, especially when we're looking at optimal transferrin, which is 2 to 2.5 grams per litre, and optimal saturation, which is 20 to 30%.
Yep.
Yeah.
And all of those things, you're probably listening to this being like, oh my gosh, that's a lot of numbers and maths.
Yeah.
It's like, that's okay. This is why we're talking to Steph, because there are people out there that have got this like iron equation and iron, you know, how things are working with each other. You know, they can see the patterns. So you don't have to, but you need to know that like there are certain patterns that we are looking for. And also just even the fact that, you know, that whole more is not better, like you can get a whole bunch of symptoms from too much iron. So it really is that case of like too much of a good thing, and those optimal reference ranges may not be spoken about with your primary GP carer, but they are out there and they're going to be specific for gender, age, sex, weight, or, you know, life stage, all those things like you mentioned. So that is really good to know.
These conversations, I think, are very important. You know, I've been talking about this for some years, and in that time, we've started to see updated pregnancy reference ranges for each trimester. So how cool is that, right? So it's a sign of the time. So I feel very positive that eventually we'll at least have gender specific reference ranges, which would be an amazing next step. Obviously, then that's still not perfect, but it drives me crazy that we're comparing a 45 kilogram female to a 100 and something kilogram male, right?
Yeah.
That's just crazy. That's lunacy. So times are changing, but with the work that I do, you know, my biggest role is education. So my clients then know what their optimal reference range is. So then they test every year. We're no longer working together or what have you. They then know what their goal is, you know. So it's bio-individual. Like I know myself, my iron studies very well. I'm not going to ever have a ferritin of 50. I've got hemochromatosis genes and high estrogen genes. It's not about me, but I want my client to know, okay, so we can see that you've been 42 before when this was going on and you weren't pregnant and your period was normal. So let's set you a ferritin goal of 42, not 30, not 100, what you have achieved historically when you were in your optimal health picture and an appropriate life stage.
I love that. Yeah, it's about that knowing, that empowerment. What about B12? Is there those optimal reference ranges for both serum or active, or how are you, you know, versus those reference ranges? How do you kind of interpret those?
Yes. So I mentioned before with the active B12, we go for above 100. Now, serum B12, I think our industry is probably is a little bit conflicting about this, but somewhere between 400 and 500 we usually look for.
Yep.
So quite different to the reference range, of course.
Yep.
But we're looking at optimal health.
Yeah, good to know. Again, could be very different for your circumstances and if you've got pernicious anemia or whatever your cause is. But again, these are some things which, you know, we're looking for that may be slightly smaller ranges than what those big reference ranges are giving you. Let's talk about, so when we have deficiencies, how do we start treating them. And there are so many questions that I have about this. So I'm going to try to like break it down so then we don't have like, you know, information overwhelm.
Yes,
But I
of
maybe
course.
want to start with transfusions for iron. I know that I'm kind of jumping past the supplement,
That's fine.
conversation, but I guess from a transfusion perspective, what's good, what's bad about them, when do we need them? And again, this is not prescriptive. This is just, each person will have to talk with their care team to know like when it's appropriate for them. But like, what are the pros and cons of getting transfusion as a way of addressing an iron deficiency, knowing that it's not actually addressing the root cause, but I guess just getting those levels up?
Yeah, I know. So firstly, I'm really aware of my biases here.
Hmm.
I talk about all my clients with regards to iron infusions. So firstly, what is an iron infusion? It's basically when iron is delivered directly into the bloodstream. So
Hmm.
it's like if you've ever had like an IV infusion for nutrients, it's like that, but it's iron. But it is synthetic iron. So
Mm.
remember, it is a heavy metal. And the standard protocols are really heavy. They're really, really, really high in the amount of iron that they use,
Yeah.
right? If we look at the research, the only people that truly benefit from an iron infusion are those that have progressed to IDA. So remember earlier I said we do treat that differently. And
Yep.
what I meant was, well, that is where an iron infusion would be recommended.
Yep.
So I always say to my clients, like, even though I think there are side effects, which we'll talk about when it comes to an iron infusion, if you have reached the point of IDA, as in if you have caught it earlier,
Yep.
then perhaps an iron infusion is something that we do once,
Yep.
which then obviously tops you up, gives you back that quality of life, can mitigate most of the symptoms. Then we treat the root cause, and over the next 3 to 6 months, we stop that reoccurring.
Yep.
In the medical model, they're handed out like lollies.
Yeah.
There's no root cause discussion. So she is then having an iron infusion every 3, 6, or 12 months on that roundabout until she suddenly realizes, like the light bulb goes off, hang on a minute, why do I need this in the first place?
Yep.
How can I stop this? And that's usually where they come and see you or I, right? Because they just think it starts to become insane, because it
Yeah.
is.
Yeah.
Because you shouldn't be going through that iron so often. However, that's where there's a time and a place.
For sure.
You can do things like request half doses, which is something that I tend to look at with clients because remember, it's a heavy metal. So it's going to come with a lot of oxidative stress. That's like inflammation, oxidative stress. The higher the dose, the higher the risk of a reaction.
Mm-hmm.
And some people get really severe anaphylactic reactions. Some just get like an iron staining or something in between. But, they are reported as rare.
Yep.
But they still do exist. So that's where it's always like a pros versus cons conversation.
Yeah.
So hemoglobin below range. So below your reference range, right? So that would be like around about 120 grams, 125 or 120 grams per liter for a menstruating female. Different in pregnancy, but we really try to avoid iron infusions in pregnancy if possible. One, they're not approved for trimester 1, so not safe. 2, if you monitor pregnancy pretty closely, you will usually not go anywhere near true IDA because the hemoglobin reference ranges drop. So it's 110 in trimester 1, 105 in trimester 2, 100 in trimester 3. But the problem is she's not being compared to a trimester reference range. So a lot of people think they're anemic when they're not relative to pregnancy.
Yeah.
But iron infusions, like they're well overprescribed.
Mm-hmm.
I don't use them in iron deficiency, but they can be a short-term solution for IDA, but ideally only once, not that roundabout.
Look, because I've seen it as well in some of my patients where I'm like, oh, okay, we're back with and they'll come to me saying, oh, I've just had an iron infusion. And I'll be like, wait, what, like, didn't you get one like six months ago or 12 months ago? And so again, it's this question of like getting people to think, maybe why, the underlying cause. But great that you're kind of pointing out a few pros and cons. And there is a time and place. It just may be a lot less often than what is currently, being handed out. What about, I guess, those B12 injections? When are they appropriate? Are there pros and cons to those? Yeah, because that's also, again, I find there are patients of mine that's like, oh, I've just had my B12 injection again. So
Yeah, I
Yeah.
think that less cons in terms of the heavy metal side when it
Yep.
comes to iron. I think the main point is the main issue is the lack of the conversation around the root cause,
Yeah.
because the patient doesn't really think like we think.
Yeah.
So they just think that they need to have one every 6 months or sometimes every 3 months. And I just think that's doing our patient or our client a disservice.
Mm.
Same with iron supplements. Like you see online people who talk about how they've fixed their low iron, but they're taking iron supplements. Now, I'm not against iron supplements in the short term.
Yeah.
But if you need to take them long term, you still haven't fixed the root cause. So it's
100%.
not really a solution. It's fine in the short term. I don't want you to have the symptoms and the quality of life piece, but it's not root cause. It's still not root cause.
Yeah, there's a dependence on it, which again, it's like the next question should be why. So let's go on to iron supplementation because there's heaps out there. There's a few which I know you and I will likely hate.
Throw in the bin.
Yeah. So can we please talk about the forms, the really low, really high doses, like how should, and again, just to reiterate, there's no prescription here. We're just talking about, you guys, information for empowerment. What are we looking for in an iron supplement and why would people be looking at high or low dosing in certain forms?
Yes. So I think considering most people still go to their doctor as like a default, they're going to be really recommended one of two products. Usually it's Multifer or it's Ferrograd C, which is just the vitamin C inclusion product. Now, both of these companies are like pharmaceuticals. They've done an incredibly good job in their marketing campaign to tell you it's well absorbed and it's a great form of iron and there's no side effects and fewer interactions and all the things, except that's just not what we see on paper, right? They're pretty aggressive forms of iron, like obviously very synthetic, quite high dose, well known to cause a lot of GI side effects, black stools, constipation, nausea. And a lot of the prescription of like the one a day, that higher dose, actually creates an issue with our own iron absorption. So we have something called hepcidin, which controls iron absorption. That's really the Goldilocks piece, as in we only have a certain amount of iron that we can absorb every day. Beyond that, if we take more, truly ironically, we'll block our own absorption, including from the diet. So we actually make the problem worse without realizing that.
Yeah.
So that's why our industry are obviously very root cause. If we do need to use iron supplements, we tend to use, the amino acid chelates that are gentler on the gut. They're much lower dose. They don't interfere with our own iron absorption mechanisms. And a lot of them have been designed to be like, obviously combined with cofactors or combined with lactoferrin for increased absorption. And then, we are really trying to optimize our own physiology while we're working on root cause so that we can come off those in the 6 months or thereabouts to follow.
And I think that is like when you understand what's happening in your body, like that hepcidin and that blockage that our body has, that's a protective thing that our body is doing. If we let endless amounts of iron be absorbed, we would be in trouble. Our body would not like that. Yeah. So again, that's probably the worst extent of trouble. Yeah.
Literally. Well, that's like what happens in unmanaged hemochromatosis. Like it's wild. Yeah.
So like this is a protective mechanism. So again, like the more is better argument doesn't apply when it comes to iron. And even like from a practitioner perspective, like in our industry, there's even ways that people are dosing that aren't even every day. They might be every second day or things like that to try and, I guess, optimize that very limited amount of absorption that, we have as individuals. So it's really interesting. And I'm not saying that everyone doses every second day. I've certainly had that dosed for me from my practitioners, and I've tried it with patients because we're seeing what's working to getting your iron up. But it's just really interesting. The more is better is actually not what we're wanting in this situation.
Yeah, and so what happens is someone will be given that 1 a day dose, and then it won't work, and they'll be told to take 2 a day, and then it won't work, and they'll be told to take 3. And it's like, well, actually, I understand that logic to a point, but it's actually the opposite. Like, less would be more for that person, right? And so that's where people always laugh at the pun, the ironic pun, but it is, because it's definitely, like you said, about protective. It's like with inflammation, when the body's inflamed, your body hides iron. It traps the iron because more would add to the inflammation that's present. Like, that's so clever. But that will look like a pseudo iron deficiency. It's actually called a pseudo iron deficiency of inflammation. So that's why we can't interpret iron studies appropriately, because your stores will look a lot lower than they are. But it's so clever that our body does that. We definitely don't want to be overriding all of that.
Yeah. Again, another reason why we're not testing when we're peak sickness is because, again, we're going to get these false levels. What about B12 dosing? And look, we do need a podcast episode about methylation, because I know that, like, this is something that people are talking about. Are we doing the methylcobalamin? Are we doing the cyanocobalamin? If people have never heard these words, please explain, like, when we're talking about forms, dosing, when it is in relation to B12.
Yeah, I think it's relative, isn't it? Like, it's a harder question to answer, because it does depend on methylation, which is like genes that are becoming very common, like MTHFR, but there's so many other genes that we need to consider in a full methylation profile. I think with B12, one of the things that's really common is people will take a supplement and their levels will be really high, and that's obviously interpreted. You can understand how that would be interpreted as a good thing. But then it means that the B12 is actually not being utilized. So it's not being taken up into the methylation cycle to keep methylation working appropriately. And then you see other things happen, like a buildup of homocysteine, and how that might impact heart health or reproductive health. Or you see a buildup of histamine, and how that can cause food intolerances like you deal with, or PMDD like I deal with, right? So B12 is quite complicated. Like, I don't do a lot of individual B12 supplementing. Maybe that's the audience that I see. But I think be aware of the forms of B12 and what is best for you. But then don't just base your success based on that blood level. You have to zoom out and start to look at nutrients, like, if you can test privately for methylation or homocysteine or histamine, you'll get more of an understanding, because there are so many methyl donors, aren't there? Right? Aren't there?
It's again, it's a full podcast we need, because, like, when people understand that there's this very complex utilization and absorption kind of picture that's playing out, you start to understand why, someone like ourselves might be like, just take, this dose for this long and everything should be fine. Like, we're having to think a little bit more holistically in that. So I guess like for people who are currently supplementing, and I think we definitely answered this with iron, but like, again, can people over supplement? Are there certain signs that you get, with each nutrient? If you're over supplementing, is it certain levels? Like, we don't want people to be on it forever, but again, I guess it's the temptation for people like, oh, I've been deficient in the past, so I'm staying on it. So can we over supplement with these nutrients?
Yeah, we definitely can. And that's why we always advise regular testing, right? Because say with B12, like, I might not even start by supplementing if we can identify that there is a stomach acid issue, or if it is a dietary. You don't meet many women who are eating more than 1 or 2 serves of red meat per week, right? And they think that's enough, but it's often not for their season, right? So I try and change the diet and the gut function first. Maybe then you would choose like an iron supplement that does have the B12 in it without it being a single nutrient supplementation. But regular testing is important, because we know that iron is inflammatory. We know that high B12 has its own side effects, as well as maybe representing something else is going on with impaired methylation. So if you're taking a supplement, I think it's important to test at the very most every 6 months. But especially initially, I really like, if possible, 3 monthly. Now, if you're below range or above range from a Medicare standpoint, your doctor should allow you to retest,
Yeah.
right? So that's kind of almost like the easy situation because there isn't a testing budget that we have to allocate for.
Yeah.
When you're in range, your doctor probably will find it hard to send you off for additional testing more than annually. So that's where it's important to have a conversation around that. Like, is it something that we need to test for privately, or will the doctor do it every 6 months? Because it is very much a case-by-case basis.
Yeah.
But just look at it closely, because ideally you're also working on the root cause. That should decrease the timeline that you need SUPs for.
Yes. Yeah. I love that. And again, that's just why we never guess. We're always kind of testing just to make sure we're on the right path, and, you know, pulling out supplements when we don't need them. So we're not over supplementing or unnecessarily supplementing, or it needs to be adjusted. So I think that testing, like you said, super important.
For iron, just one more thing. The big one for iron is if your saturation, so if your transferrin saturation goes above 30% for a female or 40% for a male, you're taking too much.
Yep.
So that's where if you've been doing it every day, you could just drop out 1 day a week, or you could drop out 2 days a week. It's sort of like how I would wean someone off thyroxine, right? You can wean off an iron supplement very slowly by taking out 1 day a week and trying to keep yourself in range. Once your saturation stays in range, then you're not blocking your own iron absorption. As long as you're not losing excess, you'll be able to start to build your surplus, which is your ferritin, your storage in the liver.
Yeah. Good tip as well. It doesn't, there's a way to do it. So we've mentioned as well, there's a few foods. We've talked about like heme and non-heme, but like, you know, when we are maybe assessing the diet and we are like, oh, I'm not eating anywhere near enough that I need to be eating. What are some of our best food sources of iron and best food sources of B12?
Red meat.
Yep.
And no one likes to hear that. I mean, thankfully, carnivore has done us a bit of justice because people tend to be like on team meat again. Not that I agree with full carnivore, but I think meat is the OG superfood. Obviously, it is high in protein, but it is so nutrient dense compared to like a protein like chicken, right? Which is kind of like just protein.
Yeah.
Your meat gives you, you know, perfectly balanced cofactors as well. So that's where nature will always win, right? Because nutrients don't exist in isolation. Like a pure iron supplement does not really make sense, like evolutionarily, like, right? So I love red meat, but when we talk about cofactors for iron, we're always thinking retinol, so preformed vitamin A and copper, and that's where organ meats come in. So yes, I am talking about liver. Clearly, the liver supplement industry or the organ meat supplement industry is as huge as it is because us Aussies don't necessarily have liver with our breakfast or steak and kidney pie, do we? But we can take supplements in a capsule form like Cell Squared.
Yes.
Or they have the beautiful powder that you can sprinkle into your spag bolognese or your butter chicken if you're not eating that much red meat, right? So the cofactors are really important.
Yeah.
If you can get it from the diet, great, like liver pate with your seed crackers or your Mary's crackers, but there are sups that can make a really big difference. And I don't really look at those as supplements in the same way that I do iron because it's a food.
Yes.
You're probably not going to eat every day because it is coming from an organ. They can be a really good long-term supplement.
Yeah.
But the iron supplements and definitely those synthetic nutrients are the ones that we're looking to use short-term only and wean off.
Well, I mean, we're always thinking about like what is a sustainable practice that we can do? And, you know, if it is, you know, having a bit more red meat every now and then, if it is kind of adding in a bit more of an organ meat here and there, that is hopefully becomes a bit more of a sustainable practice than needing to have that vitamin. And I think for people who, well, I want to ask you next about for people that aren't red meat eaters, but for people that are like, oh God, it doesn't sit right with me. Like I think those then ways of like slow cooking, like how you cook it, there may be digestibility issues with that. Because again, like, you know, in my cohort of people, like digestion isn't their strong suit. So having something heavy and rich like steak, you may be better doing a slow cook to maybe get those nutrients but help with that digestibility. But if people are like, I'm not a red meat eater, I'm vegan, veggie, or I don't like it, what other food sources can we be considering?
Yes, and I'll answer your question in a second, but isn't it funny how whenever you say red meat, people think that you mean steak?
Yeah.
Like, that's literally everyone's first
I don't
thought.
eat steak. Yeah.
Whereas, yeah, like, no, I just said red meat. I didn't even say the S word, right? So
Yeah.
that can be however you like it. Beef,
Yeah.
lamb, mince, slow cooked sausages, patties. It doesn't even need to be a steak ever,
Yeah.
right? And so we have to keep that in mind that, of course, if you can't digest red meat, that's a white flag in itself. So
Yep.
maybe you want to look at what's going on with your stomach acid or your
Definitely.
infections, like you work with Rach. But equally, it does not have to be steak.
I didn't even realize that I did that, but that's such a good point because I mean, obviously, like
Yeah,
I know
people do
that
that to me all the time.
yeah, and you're like, yeah, I didn't say that, but that's such a good point where it's like, hey, there's actually more than just a big rump on your plate that that you could be eating. I'm so glad that you mentioned that. But
Yeah.
outside of the red meat realm,
Yeah.
what are the other foods, again, if you're not a red meat eater at all?
Yeah, there's obviously non-heme forms, which we spoke about before, are best combined with vitamin C, like our spinaches, legumes, pumpkin seeds. They're the ones that we have to be really careful, though, obviously, to not then have with coffee,
Yep.
with supplements containing calciums, including prenatals. And you'll often see, that sort of vitamin C conversation come up, like have lemon or orange or vitamin C supplements at the
Yep.
same time, right?
Yep.
B12 you can find in eggs and dairy and like fortified plant foods, nutritional yeast, but again, that's fortified, so it depends on the individual.
Yep.
Yeah, B12 is mostly animal products, but there are some options that are, of course, plant-based as well.
And I think again, for people who are, even for those that are omnivores that are eating meat, it doesn't mean that you can't have an iron and B12 deficiency. Like eating these foods here and there doesn't actually guarantee you have good levels. This is what we're saying. So it's not just the plant eaters, the vegos or the vegans that were like, well, you're missing out on these. Like there are plenty of omnivores out there that we're having these conversations with. So it's, I think everybody just being more aware about how they can kind of utilize their diet to kind of fit their preferences.
Totally. There's an ethical conversation as well, which comes with
Definitely.
sometimes like a financial conversation,
For
depending on how
sure.
you purchase your meat. So it's pretty nuanced, isn't it? But I
Yeah.
think for me, I find that most women tend to undereat red meat for
Yeah.
various reasons. It could be ethical, it could be digestive.
Yeah.
That's where it's like a little bit tricky because they are in the life season where their iron
Yeah.
requirements are harder to meet versus postmenopausal. You could probably leave red meat, couldn't you?
Yeah.
Yeah.
You're not having that loss that you spoke about. So I guess if someone suspects or know that they have low iron and or low B12, what's one thing that they could start doing today? What would be like your practical today takeaway that you'd be wanting to let people know, start doing this?
Yeah, well, I think for women, log your menstrual blood losses. Work out if you sit
Mm.
in between 40 and 80 mils. And if you don't, truly start to think about that being a driver that needs to be investigated. Because for a lot of women, once we fix that, they don't have low iron anymore. So they can put that down, which is amazing, right?
That's very cool.
Yeah, I also think a dietary stock take is important. So whilst it takes time, I think using something like a chronometer or even a good old MyFitnessPal just to log what your diet looks like. Because, everyone talks about, even like this is a little bit off topic, but it's a common example. Everyone talks about how important it is to eat 30 grams of fiber a day. How do you know you're doing that?
Yeah.
Unless you literally can eyeball food like maybe you or I can, you don't know that, right? So log your day, have a look at if you're even meeting the RDIs. Now they're obviously at the bottom of the barrel. They're not optimal health, but then you get an understanding of where your dietary blind spots are.
Yes.
And then you're doing like a stock take of, right, all right, well, where am I lacking? Is it protein? Is it iron? Is it fiber?
Yeah.
Think about those cofactors as well. Is it something that instead of starting with an iron supplement, could you start with a cell squared beef liver and spleen capsule or powder and look at doing it via food first?
Yeah. Yeah.
But always thinking root cause, right?
I think again, like both of those things, it's really about, it's an awareness exercise because what we were talking about is like there just isn't the awareness there. And you're so right, like in terms of people eating and like any client of mine or many clients of mine, like, oh no, I definitely eat enough fiber. And like, and I definitely eat enough this. And then it's like, let's do a log for a week and let's like, let's have a real kind of look at it. And more often than not, there's a bit of a surprise where they're just like, I thought I was eating more.
I do it with my protein. I'm like, oh my God, I'm shocking at the moment. Because,
Yes.
like you're just having this smoothie and 2 eggs and you're like, oh, that's so low. It's like, we all need to do that stock take to check on our blind spots.
And it doesn't need to be forever. So this isn't also about us being like controlling things, but little intermittent kind of like stock takes, can really kind of help the journey. So again, don't be worried that we're saying now everyone has to track their things indefinitely. Just like stock take for a little bit.
Just
so
the average intake can often be enough, right?
Exactly. Last question, Steph. Number one piece of advice for someone navigating iron and B12. It could be something I've already mentioned or something completely different, but what's your number one piece of advice?
I think work with a practitioner who knows how to understand the reference ranges suitable to you.
Yeah.
I think it's really important to understand if there's a true issue or if, in fact, you're being compared to a reference range for somebody else.
Yeah. I think from everything that you've said today, that is probably the best message to end on, because we're not comparing a 100-kilo man to a 50-kilo, 20-year-old woman. Like we have to be looking at it differently. So I think that's a very smart thing to be ending on. And yeah, I hope people kind of listen to that, remember that next time they've got an iron or B12 issue that they're facing or currently facing, that it's, pick the right person and you'll likely kind of get better. Love it. Thank you so much, Steph.
My pleasure. That was so fun.
Amazing chat. We'll have to get you back on.
I can see little subtopics that we can branch out on. So many different things.
I know. We'll have to get you back on. I think especially like a great methylation chat or something like that would just be mind-blowing.
I need to get Sage on for that as well.
Yeah. Oh, look, we'll talk. But yeah, thank you so much, Steph. That was amazing.
My pleasure. Thanks for having me.
Thanks for tuning into Gutsy Talks. I hope today's episode left you feeling inspired to take the next step in your gut health journey. If you're ready to dive deeper, head over to rachellarson.com.au. There's a range of courses and resources waiting for you. If you loved this episode, I'd be so grateful if you shared it with others who might benefit from this information. And so you don't miss out on future Gutsy Talks, be sure to hit follow and leave a review. I'd love to hear your feedback. I'm Rachel Larson, and I can't wait to connect with you again for our next Gutsy Talk.